how do you go about making the diagnosis of discogenic pain or pain coming from the disc, Bradley?
Like we've talked about before, Nick, it's
the joint below that, the sacroiliac joint, is also a common cause of pain. And this is same. It's a mechanical pain. It can sometimes occur.
a SPECT CT is a nuclear medicine scan or triple phase bone scan. And what it involves is injecting a dye into a patient. Am I sounding like a broken record now?
No. So the only way to diagnose facet pain, one of the big ones we see in this practice is we see people that have had some form of spinal surgery and now have back pain and or leg pain. So when somebody comes to you with spinal surgery and they've got back pain, it's a different kind of algorithm that you go through in your head, isn't it?
Yeah, absolutely. Well, it's a different spine that they're coming with.
Yeah. Okay. So talk me through just some of the things. There are 5 ways that you manage pain. And if you manage pain just with number 4 and you haven't thought about the others, then you're not going to win. You're going to miss out. And it's as simple as you've had an MRI scan. It shows a disc bulge. So that's the problem, right? Not always. Welcome back to the Pain Diaries Podcast, where we share truths, treatments, and experiences related to chronic pain. One honest conversation at a time. I'm Nick Christelis. I'm a pain specialist physician, co-founder of Pain Specialists Australia, and today I'm joined by Bradley Lewinson, who is a senior pain specialist in our practice. Hi, Bradley.
Hi, Nick. Thanks for having me here today.
Thanks for your time, and thanks to the audience's time as well. So today we're going to talk about the most common, the most misunderstood questions relating to back pain, where the pain is actually coming from. Because if you don't get the right diagnosis, you can't get the right treatment. And I've said that time and time again, and I'm sure you've seen that time and time again. The reason that this got me thinking, or the reason I got thinking about this, was because how many times has somebody come into your office and said, I've had a scan, it shows this, that's my problem?
Lots of times. And people can become very fixated on an MRI scan or an X-ray where that may not be the underlying issue.
Yeah. Agreed. This practice has been open now for more than a decade. It's treated more than 22,000 people. So we know a thing or two about diagnosing. We know a thing or two about treating chronic pain. So back pain. Bradley, a patient comes into your office and says, I've got chronic back pain. Where do you start? What's the starting point?
Well, it's going to sound a bit dull, but take it back to basics. And what we tend to do is start off with the usual history, clinical examination, and then we may have a look at the imaging as well. And I think out of all of those 3 things, the big component is history and examination. And what we want to understand is there any red flags that we need to be worried about with your chronic back pain? What kind of pain pattern you have with regards to your back pain? And then follow that up with confirming our suspected diagnosis with a clinical examination, which takes time to get that clinical acumen and experience behind you to try and tease out what different elements may be involved in this patient's back pain.
Okay. So what I want to do today is I want to talk about back pain. I want to talk about chronic back pain, and I want to go through the various causes of chronic back pain, because if you have an understanding about why you have pain, where the pain is coming from, then you can get the right treatment. So as you've said, back pain it's not a diagnosis. How many times has somebody said to you, and this is from the medical world, I'm referring somebody to you with back pain, and it's not the diagnosis. Back pain is a symptom. Pain is a symptom. Sometimes pain is the problem in itself, but we'll get to that. And of course, as you've just said, images don't correlate with pain intensity. Images don't correlate with diagnosis. Images don't always correlate with what's going on. And there are various reasons why people can get back pain. So let's talk about things in turn. Firstly, let's talk about mechanical pain. Let's talk about the discs, let's talk about the joints, let's talk about everything that could cause back pain. So discogenic back pain. How many times, and you've already said this, has somebody come to you and said, it's my disc, doc, my disc is bulging, my disc is the problem. How do you diagnose disc pain, or what does it look like? What does it feel like, and how is it diagnosed?
Good question. The patterns around disc pain can be very variable. So when you've got a disc that prolapse, and it is the issue, most patients tend to have this neuropathic pain around their lower back, and they describe it as a kind of ball of pain that can move around. Usually gets worsened by most instances bending forward, because when you bend forward, what happens is the bones come together and accentuate that disc bulge out. But it can also happen on hyperextension as well, because what you're doing is trapping some of the disc, because the disc has two components to it. Inside the disc, there's a gel-like substance, and then around the disc, there's this fibrous tissue called the annulus fibrosus, which has a lot of pain fibers in it. And that tends to be the sensitive part of the disc. And this gel matrix is made up of water and proteoglycans, and that can then bulge out in this really thick fibrous tissue bit. And the pain can sometimes radiate down the legs, and it will move around and tend to be worse on static axial loading as well.
What's static axial loading for those that don't know?
Static axial loading is when a patient is going from, say, a seated to a standing position. You load up the disc mechanically, or you're standing there for a prolonged period of time with pressure on the disc. So patients quite often say, my back really aches when I get in and out of a chair, or I'm standing at the counter for more than 15 to 20 minutes. I can't do that. I have to sit down and rest. And even when they're lying flat, usually the pain doesn't completely go away.
That's a good one, because discogenic pain, which we'll come to other pains in a second, but if you compare that to, say, a joint pain is a purely mechanical pain, isn't it? Whereas the disc pain, when you're lying down in bed at night, you can still have the pain. And when you're moving around a little in bed at night, you can still have the pain. And that tells you that this is more than just a mechanical pain. How do you go about making the diagnosis of discogenic pain, or pain coming from the disc, Bradley?
Like we've talked about before, Nick, it's a complex process, but it involves taking a thorough history from the patient, examining the patient to look for other signs of where the pain could be coming from, looking through some of the imaging. And like you said, imaging is not the be-all and the end-all. What you're using the imaging for is to confirm your suspicions based on your history and your clinical examination, and then it's confirmed with some imaging findings. And
what imaging would you look at? What would you seek?
So the only one that I'm going to look at for a disc is going to be an MRI scan, because the other imaging modalities don't show up the soft tissues as well. And you can infer if there's a disc issue from an X-ray or CT scan, but you can't see the extent of that disc prolapse without an MRI. And the other thing I'd bring up is, don't forget that what we're looking at, as you've said, Nick, is we're looking at a picture. It's an image. It's a static point in time. Just because you see that disc bulge there doesn't mean it's going to be there always, because the body's changing. And you're taking a still image of the body, which may look different in time or may have looked different in the past.
All right. So I think there are four things that I would use for diagnosing discogenic pain. That type of pain, so the story is absolutely important. You examine the patient and make sure you can't get pain from other locations, because then it might be the pain is coming from other locations. Then the scan, of course. And that scan shows a characteristic characteristic features around the MRI scan, which I'll show the audience that's watching this. And there are some things called modic changes, aren't there? And the modic changes are the bones just next to the discs become inflamed, or you can infer inflammation from the MRI scan. Do you use a SPECT CT scan at all? And what is that to diagnose discogenic pain?
It can be useful. Like we've said, all of these scans can be useful based on your clinical examination and your history. So a SPECT CT is a nuclear medicine scan or triple phase bone scan. And what it involves is injecting a dye into a patient that's a radionuclide isotope dye that's labeled. You take a CT scan, and then you overlay it with the images from the nuclear dye. And what it's essentially doing is showing you metabolically active tissue. So if there is inflammation, like you've said, you can see in an MRI with these modic changes, you can confirm it with something like a SPECT CT scan to see that this disc then lights up with metabolic activity, showing you that there's ongoing inflammatory processes in the disc.
So it helps confirm or helps support the diagnosis. I was talking to a neurosurgeon recently, and I said to him, do you use, or the topic of discography came up. And discography is where a needle is put into the disc and the disc is essentially stretched while the person is awake. And if that triggers the pain or reproduces the pain, then that is deemed diagnostic of pain coming from the disc. And you've got to do that to a normal disc as well and put a bit of pressure in the disc, and essentially there is no reproduction of that pain. Do you use discograms? Is that still a thing?
I don't do discograms on a routine basis, and mainly it's because clinical suspicion and the other modalities that back those up tend to be quite good these days.
Yeah.
And the caveat is that when you do the discograms, it does introduce a small element of risk, and that tends to be an infection around the disc. Now, obviously, people do these in the most sterile way as possible, but usually with the imaging, you can infer which disc is at play. However, in certain cases where there's multiple levels that may have disc issues, a discogram would help with your specificity and sensitivity to see which level is mostly at play.
So maybe in a very small select group of patients. Okay, so that's disc pain, degenerative disc disease, and sometimes annular tears, those kinds of things where the disc can cause the problem. And the disc, like you've said, is rich with pro-inflammatory substances. So when the disc bulges or there's tiny micro tears, it causes inflammation around the area, and you generally get a classic picture. But of course, a disc can bulge and pinch a nerve, and that's where you get a pinched nerve, nerve impingement, and then you get pain down the leg, which is not back pain. So we're talking today about back pain. So discs can actually trigger pain down the leg, which most people are aware of, and that's called radicular pain, and that's pain from a disc, but the pain is experienced down the leg. Different discussion. Let's move on to some of the more common causes of chronic back pain. So the mechanical, the purely mechanical pains. And the next one is the facet joints. Tell me a little bit about the facet joints and how you would diagnose facet pain, or how it would present to you in your clinic.
So the facet joints are the mechanical loading structures of the spine. So it's part of the way that we distribute the forces through the spine and allow also the spine to move forward and backwards. So when you move forward, the facet joints move away, usually in the lower part of the lumbar spine. And when you move backwards, the facet joints come closer together. With everybody, we all get an element of osteoarthritis in our joints as we age. And there's a natural level of osteoarthritis, joint degeneration, that will happen with time. And some people have a bit of accelerated degeneration of these joints. And with that, we'll tend to then produce an inflammatory cascade in the joints. And in some patients, not every patient, that inflammation and that osteoarthritis will then start to give you pain coming from those joints. There's other issues that the joints can go. So there's some autoimmune conditions as well, like rheumatoid arthritis, ankylosing spondylitis. And these are when the immune system's super activated and then starts to destroy these joints. So there can be other reasons behind it, but generally it tends to be what we term as a wear and tear of the back joints.
Okay. Yeah, not the right terminology. I had a patient come to me once and talking about discs, and she said to me, "My surgeon told me my discs were like biscuits and they were crumbling all around." And that just put the fear of God into her, and she didn't do anything. She got stiff, she got weak, she got deconditioned, and we've got so much to do to get her back on track again. So what the words we use are so important to people that we treat with pain. So the facet joints pain is okay when they bend forward. It's not okay when they bend backwards. Sometimes when you twist and what we call load the facet, it hurts. When you examine the facet joints, when you lie a person on their front and gently examine them, you can trigger the pain. And of course, the pain is generally not that ball of pain like a disc pain, but it's pain, we call it paraspinal, on the sides of the spine. And of course, that can run all the way up. And of course, it can be a cause of chronic neck pain as well. But we're talking about back pain today. How do you diagnose facet pain?
Am I sounding like a broken record now?
No. So the only way to diagnose facet pain is to do diagnostic medial branch blocks. I would have said, you've got to put the picture together, the history, the examination, sometimes with or without tests. But then the only way is to find those painful facet joints, put some local anesthetic on them, and assess the pain afterwards. And if the pain goes away, then the pain is coming from the facet joints. That's called a medial branch block. It's not a facet joint injection, but it's a similar process. It's a little more scientific, a little more precise.
Nuanced.
Yeah, a little more nuanced, a little more precise. And then, of course, if you've got the right diagnosis, you can apply the right treatment. But today we're talking about diagnosis, not treatment. So the bottom facet joint, Bradley, is the L5S1 facet joint. The joint below that, the sacroiliac joint, is also a common cause of pain. And this is same. It's a mechanical pain. It can sometimes occur after pregnancy or during pregnancy. It can sometimes occur after trauma. It can definitely occur after lumbar spinal fusion, because that sacroiliac joint can take the load from the facet joints that have been fused. And that is a particular kind of pain as well. It's lower down. It's on the top of the bum in that V shape, either one side or both sides. It's a movement-related pain, and it's confirmed by, we call them provocation tests. So on the examination, we do a little bit of movement, and that can trigger some of the pain. And then, of course, the diagnosis is made by putting some local anesthetic, sometimes a little bit of steroid in or around the joint, and see if the pain goes away. What provocation tests do you use, Bradley, to help you diagnose sacroiliac joint pain?
So there's generally 4 provocation tests that we use. They've got names associated with it, and I won't go through it because it won't mean it very much. But what we tend to do is try and get the joint to move in different directions. And because the joint is this big complex joint, you can obviously cause compression of the joint. You can move the joint forwards and backwards, and then we try and get some of this rotational component with the joint when we move the legs around. So we pull the thigh all the way up, or we use the contralateral thigh to try and move the joint and get some movement in that area. The other thing is that sometimes this joint, because it's so big, just like the L5S1 facet joint, can get this paraspinal pain distribution going down into the buttocks. With the sacroiliac joint, you can get a bit of that pain going down the leg as well. And it can shoot down usually the outside of the leg almost into the calf. And some patients may say, I've got a pinched nerve, doc. And you say, well, actually, it doesn't follow a pinched nerve territory distribution. It's following more in the sacroiliac joint distribution. Let's go and do a diagnostic test on that joint and see if your pain goes away.
Got it. All right. Let's stick with mechanical causes. Let's talk about muscles and tendons that could cause chronic backache. Where does this fit in? What does it look like? I suppose for me, it's more the acute back pain that happens to a lot of us. It's happened to me. I'm sure it's happened to you, Bradley. It'll happen to a lot of people that are watching this or listening to this. That acute pain where you overdo something, you stretch a muscle, you sprain a muscle, and you get a different type of pain. So what does muscle and tendon pain look like, Bradley?
Well, from the patient's perspective, not much difference because it hurts like hell. And you say muscle and joint, get over it, it'll be fine. But what tends to happen is that because the back is such a sensitive area, if you get muscle strain and a sprain in that area, the muscles will actually go into this spasm and they'll lock down. And any movement where you try and pull those muscles apart will be exquisitely tender in that area as the spine tries to protect itself.
So exactly right. So if you stretch your calf or get a cramp in your calf, you know what it feels like, don't you? You can stretch it out. But when you get a pain in your back or when you get a cramp in your back, you're on the floor. That's it. You don't know what to do.
And every movement will then trigger off that pain. You can't move your legs. Even some patients, deep breathing will then trigger up some of that pain, and it can be agony.
Yeah. Okay.
The problem also comes on if that muscle pain then stops patients from moving, and they lose those muscles because it's an important part of the functional unit of the lumbar spine.
Yeah. We know we're learning a lot more about muscles, and one of them, as you and I as pain specialists know, is the deep muscle stabilizers of the spine, the multifidus muscles, and there are many others, of course, and we know that sometimes that can be the driver of chronic severe refractory pain. Okay, so that's muscle and tendon pain. Let's move on to nerves. And there clearly are many nerves in and around the lower back. And when you say I've got back pain from a nerve, a lot of time people think, well, it's a bulging disc, it's pinching a nerve, and I've got this severe pain down my leg or obviously arm. And if we're talking about the neck, but we're focused on the lower back here. So how can nerve pain present itself when somebody comes to you and says, I've got chronic back pain, I've got back pain, doc? What does it look like to you?
Well, it could be one of two varieties. You can get central neuropathic lower back pain, where it hasn't quite pinched on, or there's no inflammation around the nerve root, and it's all around the descending nerves in the spinal column. Or you can get a radicular type of picture, where you're getting pain shooting down the leg or the arm. And that tends to be a very nervy-like pain. So patients use particular descriptors to describe it. So I'm getting a burning, shooting, tingling, pins and needles. It's there all the time. It's exacerbated by activities, and it gets worse at nighttime usually.
Okay. So that's the central cord that gets compressed, and there's no shooting pain down the legs, and that's called central canal stenosis, like you've said. And that causes something called neurogenic claudication. So that happens in generally older people. So you don't think about it if it's a younger person. Generally, of course, it happens in older people. The more they move or walk, they get this burning pain down both their legs. They need to stop, rest, and almost get more circulation in that area to relieve the pain, and then they go on again. So that's neurogenic claudication. And then, of course, like you've said, there's that radicular pain where the disc pinches a nerve and you get that shooting pain down the leg, and it's a different kind of pain. Exactly right. I'm going to mention a nerve called the cluneal nerve, which most people may not know about. They'll see a picture of this, but please tell me about cluneal nerve entrapment or cluneal neuralgia, Bradley?
Well, cluneal nerve entrapment or cluneal neuralgia is a common form of lower back pain. I think it often gets missed off in a lot of patients because not many people, like you said, Nick, know about it.
Mm.
It was first described by Andrea Trescott. I don't know if I'm butchering her surname or not. And it's two nerve fibers that branch off from the thoracic nerves that then travel over the lumbar fascia, and I'm sure Nick's probably showing you a picture at the moment, and then radiates into the upper buttock area, and it can actually come round the upper buttock areas. And there tends to be a tender point just above the iliac crest where you can palpate these cluneal nerves, and that will trigger off the back pain. And the cluneal neuralgia usually is this lower back pain that kind of radiates halfway down the leg and is exacerbated by the muscles entrapping the cluneal nerves, triggering off this pain symptom. It's a very neuropathic lower back pain, and it can sometimes present with similar type of picture that other patients complain about, worse on standing, bending forward, and leaning backwards, and particularly at night time, causing them significant pain in bed.
Right. Underdiagnosed, not a common cause of backache, but definitely debilitating. You've got to know it, you've got to understand it, you've got to listen for it, and you've got to seek it, of course. Okay. Spondylosis. Everyone uses this term. A lot of people use this term. It's an umbrella term that just means lumps and bumps, age on your spine, and that can trigger pain. What does that look like?
Oh, it's a catch-all term, isn't it? I have spondylosis of my spine, because the spondylosis is saying that there's aging of the functional unit of the spine, which includes the disc, the vertebral body, the facet joints, the ligaments, calcification in between the ligaments as well, and it can look at various different levels in different ways, and you can get slight movements of the vertebral bodies of the spine that happen, which can cause reduction in the area that the nerves have got to go through, and further pinching in the corners of the spine where the nerves come out.
So it's a bit of everything. It's a little bit of facet pain. It's a little bit of discogenic pain. It's a little bit of central canal stenosis. It's a little bit of muscle pain. It's a little bit of stiffness. And it tends to occur in somebody that is older than somebody that is younger. Do you agree with that?
Absolutely. You can see it early onset, but I wouldn't expect to see any of those features in anyone under the age of 40-ish.
Yeah. And it's hard to make that diagnosis because they will have seen many other practitioners, and the practitioner that is got a surgeon's hat on will say, well, these are the issues, and a practitioner that's got an allied health physiotherapy hat on will say, these are the issues. But actually, it's a bit of everything, and that's the way to treat it. You've got to work out what is the most common symptom. So is it that claudication pain, or is it the radicular pain, or is it that mechanical facet pain? And treat that, take it away, and see how they are. And if that's not good enough, treat the next symptom. So it's there's a little bit of experience that comes to making the diagnosis and applying the right treatment.
And it's a bit of a journey with the patient usually, that we're going to try and tease this out. It's a complex issue, and sometimes you think you get on top of it, and then the neuropathic pain can become more evident, or the joint pain can become more evident at a later date as well.
Yeah. Right. Let's move on to another one. This is a big one. Actually, before we move on to the big one, I want to focus on the one that we've got to think about first and foremost when somebody comes to you with back pain. You've got to ask yourself, is this pain referred to the back from somewhere else? That's the first thing. Actually, I'm gonna ask you that first. If you get pain referred into the back, where could it be referred from? That's the first part of the question. And the second part of the question I'm going to ask you is, when do you have to worry about back pain? When is back pain urgent? When is back pain a problem?
Well,
so let's stick with the first one first. So where can back pain come from? Or when you see somebody with back pain, you go through these steps in your head, they're automatic. What are those steps that you go through?
so back pain can obviously come from the areas around the spine. So patients can have hip issues that can present as back pain. You can have issues higher up in the spine that present as back pain. You can have issues in the abdomen. So abdominal viscera, like the pancreas, the spleen, kidneys, can all radiate into the back. Infections of the urinary tract can radiate into the back. And I don't think. Can you think of any others, Nick?
I suppose you've got anything within the abdomen. So abdominal aortic aneurysms and, tumors in muscles and all these things. And I suppose that leads on to that second part of the question, which is, when does somebody need to worry about back pain, or when do you worry about back pain, or what questions do you ask that make you alarmed?
So we have different levels of flags in back pain, and the one that we always worry about is red flags.
Okay.
And that would be, has a patient lost a significant amount of weight in a short space of time? Is there any weakness in the legs? Is there any disturbance of bowel or bladder function? Is there persistent night sweats? Have they been coughing up blood recently at nighttime? Is there persistent other symptoms like nausea, vomiting? Is there evidence that there's a malignant process happening in the background?
Okay, so you've got to think about, is this cancer? So that's why the weight loss occurs. Is this bone metastases? So is there something in some part of the body that's referred to the bone, or metastasized to the bone, or started in the bone, and you're getting this deep bone pain? And that, I suppose, would show like spondylosis, or like facet joint pain, or of course vertebral crush fractures, which is another cause of spinal pain, which we'll touch on. So weight loss you've mentioned, so that's why you want to know about weight loss, because is there a malignant process or a severe medical process happening that is associated with back pain? You've mentioned weakness as number two. Why, or what things cause weakness with regard to back pain?
Weakness can be either a systemic process, i.e. if it's cancer, or another autoimmune metabolic process.
Yeah.
The other thing that can cause weakness is if we have a significant compression of the spinal nerves. And that would be, the nerves are so compressed that the messages are not getting through to the legs, bowel, or bladder. And that tends to be a urgent emergency scenario where we need to get the patient seen by a surgeon as soon as possible.
Okay, so weakness involves not only the nerves causing pain, but the nerves not working as well. And that's dangerous, of course. And similarly, I presume with the bladder and bowel problems, as you mentioned, the nerves are not working, and it's now affecting bladder and bowel function. Okay.
Correct.
Night sweats, why are night sweats a problem?
Night sweats can be an indication of significant malignancy or other malignant infections like tuberculosis, which can sometimes settle in the spinal cord.
Okay. And I suppose the other one would be any form of infection. So certainly one of the things around discogenic pain, if you've got discogenic pain, what that looks like, we've talked about, and you've got night sweats, is there a disc infection, which can happen?
And those night sweats are very specific, Nick. It's not just a little bit of sweating at nighttime. It's drenching the bed sheets, and then being completely wet. So profound night sweats.
Okay, so those are the red flags. And if you've got any of these red flag symptoms, or I suppose one of the other big red flags is if the pain changes, or the pain is acute and severe and relentless, and it's out of the ordinary. And I know a lot of people are going to say, but my pain is out of the ordinary. But if your pain changes dramatically, then that might be a red flag. It might signify something has changed dramatically, or you've developed a new kind of worrying pain. Alrighty. So we've talked about the various causes of low back pain, and there are definitely more, and I've still got a few more to go to. One of the big ones we see in this practice is we see people that have had some form of spinal surgery and now have back pain and or leg pain. So when somebody comes to you with spinal surgery and they've got back pain, it's a different kind of algorithm that you go through in your head, isn't it?
Yeah, absolutely. Well, it's a different spine that they're coming with.
Yeah. Okay. So talk me through just some of the things that pop into your head or some of the things that you need to go through to work out why this person has got pain and it's associated with previous spinal surgery.
Well,
I know this
patients
is a very open-ended question.
look, when you have surgery to the spine, the surgery can be of different types.
Yeah.
You can have minimally invasive surgery where the surgeon will go in and shave away a bit of bone, to putting in rods, cages, and fusing the lumbar spine. So it does depend on what type of surgery the patient's had before. After a surgery, patients can come back, and even though the surgery has been very successful at correcting the anatomy of the spine, the pain is still there. And that doesn't mean that the surgery was incorrectly done. It just means that the pain usually changes after the surgery and can move from where it was pinching on a nerve to now being involved in a bit of inflammation in the back. Because when you go into that epidural space, there's things that can happen. There's blood that can get there. They shave off bits of bone and bits of disc. And what that will do is that will cause a pro-inflammatory reaction in the epidural space of the spinal cord, which can cause some scar tissue to develop, which can cause some tractions on the nerves, and then start to precipitate some of this inflammatory process.
Okay. It's complex, and of course we're not surgeons, and we've invited a few surgeons and we're teeing this all up, so please keep in touch with the channel. I always say if the patient's recently had surgery, you've got to ask yourself if it's a surgical complication. So bleeding, has the disc prolapsed, has a screw protruded or fractured or something, and those things happen. That's part of the surgical process. If it's been a long time after surgery and they're starting to get pain and it's that nervy, radicular pain, then I think you've taught me a lot of this, Bradley, is there scarring around the nerve and you're getting this nerve-generated pain. If there's a mechanical component to the pain, you've got to say, is there problems above or below the surgery or fusion? It's called adjacent segment disease, and that can generate either discogenic pain, it can generate facet pain, and of course now we know the difference between the two. We can kind of tease it all out. What are the other ones? So if it's more than 6 months or so, if it's around the 6-month mark, is there scarring? If it's got that mechanical component to it, is it the facets or the discs, or of course the sacroiliac joint down below? If it's a new pain that absolutely started after the surgery, then it's a surgical problem. Perhaps they've done something that's triggered a new pain, and you've got to investigate that. And of course, if the pain never changed because of the surgery, and I don't know the stats on this, but the surgery wasn't done for the right pain, or the surgery wasn't done appropriately. And I know stories of where surgeons have done surgeries on wrong levels and wrong sides and those kinds of things. So you've got to ask yourself. It doesn't commonly happen, but you've got to ask yourself. And then, of course, you've got this persistent neuropathic pain that can happen after spinal surgery as well, which is just where, I don't know, how would you describe it? You get traction on nerves. You get this. It's a traumatic operation. Number one, because it's in a delicate part of the body that is protected. But number two, something has injured the nerve to trigger the surgery. Usually, so some form of trauma has triggered the surgery. You know, the severe disc prolapse or severe spondylosis and neural compression. So not only is there initial problem that damages nerves and injures nerves, but of course the surgery itself can be traumatic in itself.
And you may have had a long-standing chronic inflammation in those nerve structures, and even though you've taken away that inflammatory process where it's been compressed because of the bone, disc, or other tissues, that internal inflammatory process hasn't fully resolved.
Got it. And that brings me on to the last part of this, or the last big part of this, and that's where you have everything that looks pristine on the scan, and whether it be with surgery or without surgery. And certainly we see a lot of people that have had surgery and the surgeon said, everything is done well. I'm very happy with the surgery. I'm happy with the decompression. I'm happy with the fusion construct. That is not the cause of your pain, number one. So you're implying that the pain is in my head, doc, and the pain is not real, doc. And then number two is when the pain is absolutely, or the pain is, the scans are completely normal and the person says to you, I've got pain. Yeah, I've absolutely got pain. And are you telling me it's not in my head? So they're both similar but different, but basically it's the same thing, isn't it? This is non-structural pain. And that's termed, I still use I don't know, what term would you use for non-structural pain? I know there are different terms being thrown around. Does it matter?
Nociplastic.
Nociplastic pain, okay. Sensitization.
Central sensitization, wind up.
Yeah.
And these are all part of the same kind of process where the nervous system has an upregulation, and we try and find causes for it. Sometimes you will never find a cause why the nervous system has become sensitive. But what it tends to do is start to transmit pain signals to innocuous stimuli. So where a patient's moving their back, that gets exaggerated in the spine and gets transmitted up the spinal cord as a pain signal to a normal stimulus. Does that mean that's in their head, Nick? I think it means that what we have is altered neural sensitivities within the spinal cord in some patients, leading to this chronic pain state.
Correct. And that's how many times has a patient come to you and said, I have been to A, B, and C, and they've all said to me, the pain is in my head.
And what I try and say to patients is, on one extent, that is correct, because everything that we experience in our life is in our head, but this is not you inventing this pain. This is not a fictitious situation that you've made up. This is an abnormal pain processing pathway issue that's happened. And as a result, you're experiencing chronic pain from normal movement activities that shouldn't cause this chronic pain.
Yeah. It's a really tricky one, and it's hard to explain to patients. It's hard to get the message across. It is, you have pain. It is real. The pain is debilitating. It is absolutely there. But sometimes we don't know what the trigger of that pain is. And that's what that sensitization is. Normally there is a trigger for it. And if you have a trigger that damages the nervous system in some way, we term it a lesion or a disease. Is it a lesion or disorder of the somatosensory nervous system? I forget exactly, but essentially something that affects the somatosensory, the feeling nervous system, the sensation part of the nervous system, triggers neuropathic pain. If you don't know what the trigger was, then effectively that's nociplastic pain. It's altered pain processing without a known trigger. Was that right?
Yeah, that sounds right to me.
Okay. And then sensitization, of course, and that the back pain of sensitization is different. It can occur with other symptoms, migraines, TMJ pain, abdominal pain, fatigue, sleep disturbance, low mood. So that's the cluster of central sensitization. And that occurs in people with diagnoses like fibromyalgia. So that back pain is different. It's wider spread. It's not a little ball of discogenic pain. It's not paraspinal facet joint pain. It's not that electric radicular pain of nerve root compression. So it's that big ball. And when you examine the back with a brush or with a toothpick compared to a normal sensation or normal part of the body, it's hypersensitive, isn't it? So the brush hurts, like you've mentioned, the toothpick hurts. So there is amplification of nociception. That's the way I describe it. So it's your pain signals that have been dialed up, and patients understand 12 out of 10. It's not 10 out of 10, which is the volume knob. It goes all the way past 10 out of 10.
And the pain will move around. It won't be consistently in that same space. They'll have different days. Some days are worse, some days are better. They can't identify specific triggers for all of these things. And it tends to be also significantly linked to patients' mental health as well.
Yes.
And talking about mood, anxiety, depression, all feeds into this abnormal pain processing pathway that they're suffering from.
Yeah. What comes first? And that's the chicken and egg scenario, isn't it? Is it the mood that puts you at risk of developing chronic pain? Or is it pain that affects your mood? Is it both?
It's a good question, because we know that there's good studies out there showing that if you suffer from anxiety, if you're a particular personality type, if you have depression or previous traumas, that will put you at higher risk of developing these chronic pain states.
Yeah.
But some patients, the mood alter happens at a later stage. I think the two are so intertwined, it's very difficult to tease these two things out.
Yeah, and that's why if you've got somebody with good old-fashioned facet joint pain, which is easier to diagnose and relatively easy to treat, and the pain doesn't improve, it might be because you haven't focused on some other factors that are related, which no one's focused on. And that's what makes pain management, pain assessment, pain diagnosis so tricky. And that's why, and I say this so many times, if you've got chronic pain, you need to be seen by a chronic pain expert, a pain specialist physician, because this is what we live and breathe. And, go on YouTube and have a look at, this is how to fix sciatica, this is how to fix back pain in, 3 quick steps or 3 quick stretches. And it's not the case. It's just not the case.
Unfortunately not, Nick, because this pain affects patients in a multidimensional way, and we need to take a multidimensional approach to managing these patients' pain.
Right. And look, we're gonna slowly start wrapping things up, but one of the things I wanted to mention, because I want to give the audience something, and I'll ask you for some takeaways in a few minutes, but the way you manage pain, there are 5 ways that you manage pain. And if you manage pain just with number 4 and you haven't thought about the others, then you're not gonna win. You're gonna miss out. And it's as simple as number 1, and that's lifestyle understanding, getting your head around what's going on. Because if you know what's going on, pain is not so scary anymore. Number 2, the allied health approach. And that's where we pull in other members of team to deal with patients in some way. Number 3, of course, is the use of medications, cautious use of medications, a planned use of medications. Number 4 is interventional approaches, which I think can be life-saving for the right pain and the right person. And then number 5 is to use advanced therapies, such as neuromodulation. And of course, in that is also advanced therapies such as surgery. So surgery is there as well for the appropriate person. And if you treat facet joint pain purely with injections and you haven't dealt with the low mood, or you haven't dealt with the stiffness with a physiotherapist, you're going to fail. Or if you've treated the facet joint and not dealt with the disc part of the pain or the education part of the pain, because that patient still thinks their spine is crumbling, you're going to fail. So it's everything. And I'm sure you feel very strongly about that as well.
Absolutely. It's not one modality, it's the combination and the package of care that gets patients moving forward and not coming back into your office again.
Yeah. So you've been practicing pain medicine for how long now? We'll call it a decade. Is it 2?
Over a decade now.
Okay, over a decade. I've certainly been in the pain sphere, starting with anesthetics, acute pain, and then the pain fellowship, which is now 21 years ago, Bradley. We know stuff that other people don't know and haven't learned yet. There is so much nuance to understanding and assessing a person with pain, and I feel very strongly about the fact that if you have chronic pain, you need to see somebody that knows chronic pain. Surgeons are good at what they do. Physios are good at what they do. We put it all together again, and I feel very strongly about that. And that's partly why we're here talking before our day gets started, because it's about sharing our knowledge. So, question: with all this complexity, with all these different types of pain and causes of pain and medical conditions, how do you land on a diagnosis? So this is something that I want you to tell patients, because they go, well, I've had this pain. It's debilitating. It sucks. I don't know what to do about it. How should they go about getting a diagnosis?
I'm going to say see a pain specialist. So I think going about getting a diagnosis, Nick, would involve always starting off with a consultation with your GP.
Yeah.
Going to see them, and the GP usually is very good at getting the red flags and the initial investigations done, getting some physiotherapy in, getting some help with the mood disturbance if that's not correct, trying to correct some of the lifestyle issues if they can, and if that is not working, seeking help.
Completely agree. Most of us have had back pain. My back pain was dealt with, and I felt sorry for myself. I didn't want to do stuff. I couldn't pick up my kids, and I know this stuff, and it can affect anyone and everyone. And I said, right, I've got to do what I need to do, what I talk about. And I went to the yoga studio and I took some medications, and I was persistent for 3 to 4 months, and gradually things turned around. And I now understand what it is to look after my back and protect my back and be strong and have a good lifestyle. That's the number one part. I didn't need number two, and I used number three medications for a short period of time. So it involves all those factors. But like you've said, your GPs see more chronic pain than we do, because chronic pain is everywhere, and they have generally a good first step. If it's not helping, if medications are not helping and it's debilitating, affecting you in some way, then you need to see a pain specialist. As you know, we've got a clinic in Melbourne, and we treat thousands of people every year, and I'd like to think we're pretty good at what we do. What about investigations, Bradley? I mean, is it worth getting an MRI scan? Is it worth getting a SPECT CT scan?
In the initial stages, I'd say speak to the GP. Usually, if it's chronic lower back pain, the general indications are an X-ray, just to exclude any red flag type of symptoms that can or conditions that can cause the back pain.
Yeah.
And most patients don't need an MRI for lower back pain. If it's ridiculous symptoms, absolutely an MRI is indicated. But for just chronic lower back pain, a simple X-ray, if needed and the patient's in the right age range, would be sufficient.
Yeah. Okay. And of course, we as pain specialists and anesthetics in our background are very good at doing, and very safe and very precise at doing, diagnostic injections, which help us confirm or refute some of the diagnoses as well. And of course, those can be used therapeutically as well. So a couple of big factors, a couple of big things to get across. Number one, a scan is not a diagnosis. A scan is just, like you said, it's a point in time. It doesn't mean that is the pain. It's got to be put in context with the person and the clinical picture, number one. Number two, pain has patterns, and a good pain specialist, a good senior doctor, will know how to read those patterns and put it together. And then, of course, getting a clear diagnosis is absolutely paramount, because without a diagnosis, you can't apply the right treatment. Number four, number five, not all pain is fixable with surgery, and that's okay. Surgery clearly is warranted in some, but not a lot. And evidence-based therapies, they involve multiple professionals. Not a single person is going to cure complex pain. It's going to be a number of specialists, and we are one of those teams along the way. Is there anything else that you wanted to get across?
I think, you've covered it, Nick. Usually the spine is a very solid unit. it's unlikely that you're going to break your back's going to crumble if you get out of bed and move. It takes a lot of force to do a significant injury to a spine, and doing some regular exercise, physiotherapy, although will be uncomfortable, may be the key to trying to unlock some of this back pain symptom.
So why do patients so fearful? Why are patients so fearful of moving? When it hurts, when it hurts, you see so many people. They come in and they are fearful of moving. They are afraid of moving when they have back pain. Why?
Well, they're thinking that the pain is a signal that there's damage, and they're doing more damage by inducing more pain. But the converse is actually true, is that what's happened is you've had a back injury, now you're in the chronic phase, the back is stiffened up, and the muscles are there and not loosening up. And actually movement can be the key to getting the pain to settle down.
So is that the way you get patients to actually start moving, is you just give them a good explanation? Or have you found a tip, a trick, or something?
What I tend to do is, if there is imaging there, I'll go through and I'll explain actually what the imaging means. Because when you look through images, and I've seen patients come into my clinic with horrendous looking MRIs, but no pain. Although the image looks bad, they don't have any pain symptoms, and their quality of life and their moving in that area is pretty good. And then other patients with minor changes where there's significant amounts of pain in the background, and the two don't correlate. And what we know that helps is strengthening the muscles in the back, encouraging the functional unit of the spine, so the discs, joints, ligaments, muscles, to move together as one component, to strengthen up, because what ideally we need that back to be is a supporting structure to support the upper body and allow for ambulation and movement.
Got it. Okay, so movement is key. And movement is one of the first steps, and hence lifestyle and, of course, allied health. Sometimes we use physios and others to help get the moving happening, get over that fear.
Have you got anything that you use to tackle that fear of movement, Nick?
Same thing. Time, because it takes time to talk to somebody that's really fearful and nervous and afraid and upset that they've lost their life. So time and the pictures as well. Most of the time people come to us with scans having already been done. And that in itself, talking through that and showing people lumps and bumps, and they just go, oh, is that it? But I was told my disc is prolapsed, and well, there's your disc right there. And there are some average scans, and the patients go, I get it. And of course, they need to understand that the disc is strong. The disc is a strong part of the body. It's not just going to pop and break and fracture. And it's protected by ligaments and structures and the spine. And, this is what we've been built to do, is stand and walk and live. So it takes time, it takes explanation, it takes working through scans, and of course it takes some team members as well. And if necessary, right medication, the right interventional approach to diagnose and treat the pain as well.
Absolutely.
Bradley, that's been fantastic. I think that was super. What I'd like to do at some point is perhaps you and I can talk through some treatments for chronic back pain as well, depending on these various causes, once you've made the right diagnosis.
Sounds fantastic, Nick. Looking forward to it.
All right. Thanks, Bradley.
Thanks for having me on, Nick. And thank you to all the listeners for giving us their time. I hope this has been helpful.
And we forgot to say this is not medical advice.
Yeah, me and Nick have just been giving a generic discussion.
Oh, correct. All right. Thanks, Bradley.